Looking at zinc deficiency next, we can look at some areas where we can see widespread deficiency versus medium deficiency overall. But why do we need zinc? Well, 300 or more enzymes are associated with zinc, and the biological functions of zinc are divided into either catalytic, structural, or regulatory pathways. It has lots of roles in the metabolism. I'm not going to read them to you, but you can see them here where it's involved in a lot of different components from protein synthesis to immune function to epithelial tissue integrity and more. Across the whole body, we can see the distribution varies, and we can see that there is a gender assigned at birth component there from range of total body stores, with skeletal muscle winning the most, holding on the most, with bone kind of falling behind, and then everywhere else being pretty minimal otherwise. And we can see that in blood plasma, we have only 0.1% of zinc being bioavailable there. Again, another image looking at the zinc body composition when looking at kind of ingested zinc and where it ends up in its amounts and how long it potentially takes to go from one place to the next. There's no specific storage site I recognized. Within cells, there are amounts sequestered within methylthionine, which could be considered as stores. Um, we'll see that in anorexia, muscle catabolism, tissue zinc release, that does happen, and metalloenzymes will really try hard to cling to zinc as much as possible. Zinc turnover, therefore, because we don't have a known storage place for it, like liver for iron is extensive and rapid. So there's two components of turnover, fast and slow. The fast pool for zinc is also called the exchangeable pool, and it is going to be in amounts that are a little bit higher from a milligram of zinc component. And this is just showing an image of zinc in food. The mucosal cells in the intestines store zinc. If the body needs it, it gets released and it goes to transport. The pancreas can use zinc to make digestive enzymes, and then, again, the process continues. If the body doesn't need it, zinc will be excreted and shed. So metallothionein is concentrated in the liver, kidney, pancreas, and intestine, and it acts as a zinc buffer that controls our free zinc levels and our intracellular zinc pool, which is both responsive to hormones and dietary intake. Zinc binding protein metallothionein is involved in the regulation, therefore, of zinc metabolism as a whole. This protein is inducible by dietary zinc via the metal response element and MTF1, the mechanism of transcriptional regulation. So we'll see an increase in cellular metallothionein production, which will then lead to an increase in zinc binding within cells. Acute infections are associated with pro-inflammatory cytokines, which can increase zinc's uptake into the liver, bone marrow, and thymus, and it reduces the amount going elsewhere. So we do see this shunting effect depending on the body's needs. And this is showing kind of this coupling as a homeostatic zinc system. When we excrete zinc, we can see it being lost via hair, sweat, desquamation of our skin cells, our bile, pancreatic secretions, seminal fluid, urine, and feces. The main endogenous loss is going into the gut and mucosal cells. We also have some urinary and skin losses, which are typically less than 20% under normal conditions, but we can see those losses increase with trauma, breakdown of muscle, and any chelating agents that are being administered. We think of potentially like charcoal or things like that. Primarily in fecal material, we can find unabsorbed zinc and secreted zinc from pancreatic and intestinal sources. If we had deficiency of zinc, we could see issues in growth, issues with skin lesions like glossitis, issues with immune deficiencies or behavioral changes, even vision, night blindness, impaired taste or impaired healing or delayed healing of wounds. Appetites could change, impaired appetite or food intake, and even eye lesions like photophobia or dark adaptation. This is really a great comparison of zinc excess versus deficiency. So I like using this as a comparing and contrast system. Now, zinc has some challenges for being analyzed in the plasma. Zinc deficiencies can be manifested by a slight decrement in tissue zinc, and so an impairment could occur before we can actually assess a change in zinc concentration. Typically, internal zinc changes are really quickly corrected by a homeostatic mechanism that's pretty effective. Thus, you might not ever even see a biomarker change being turned on. And zinc's use is so widespread throughout the body and interconnected that to focus on one factor alone is not always practical. Plasma contains, like I showed you in a previous slide, very, very small amounts of zinc. And there's a great question on whether plasma zinc changes can even reflect total body zinc. Nonetheless, we do use plasma zinc as the most widely used and accepted biomarker of zinc status, as it will depress whenever an acute phase response becomes triggered. And it also can depress in hypoalbuminemia. So there is some kind of evidence or studies talking about, is plasma zinc the best indicator of zinc status? There are some other zinc indicators, cellular components like carbonic anhydrase, looking at kind of the major erythrocyte pool of zinc, but it doesn't really turn over. Membrane-bound zinc might also be a factor, maybe a better marker. This applies also to monocytes, neutrophils, and platelets. Hair zinc is maybe a good marker. But impaired growth does not correlate positively with low hair zinc levels, might be more relevant to a chronic status as opposed to a transient zinc status. And then zinc excretion requires tracers throughout and metabolic collection. And so it's more of a research-based measurement than a clinical screening. Tissue stores also require tracer and sample collection over multiple days. Metallothionein mRNA, which is a PCR test, is promising in monocytes as levels decline rapidly with a moderate dietary restriction and they increase with supplementation, but it's not standardized and used as commonly as serum zinc at this time. There are some zinc-dependent enzymes. So suppression of the following, though, is inconsistent. Alkaline phosphatase, we've looked at that, but it's non-specific. And then these others are very unique. Um, you also need to consider when you're looking at a response to zinc supplementation that dietary levels also need to be taken into account, and the response to zinc must be specific and non-pharmacologic. There's been some studies on the zinc taste method. Um, it does say that, since zinc depletion can lead to a decreased taste acuity, there could be potentially a correlation with improving zinc intake and be able to taste flavors more accurately. But it is ambiguous and it's challenging to create a study that blinds for all these variables. When we come back, we'll look at our next mineral, trace mineral, which is selenium.